So our topic for our in-service this evening is which trail are you on? And we're going to talk through the journey of skilled therapy. So our agenda is we're first going to start with the therapy process, and then we're going to jump into what is considered skilled therapy. And we're going to talk some about therapy trails and episodic care. And then we're going to talk a little bit about empowerment of families and caregivers. And then we'll have some time at the end for questions. So, as speech OT PTs in school, we learned about the therapy process. So I've got a nice graphic for you here of what the therapy process includes. So we have referral at the beginning, then we have the screening process, which kind of is combined with evaluation most of the time. We then have the intervention portion of the therapy process, and then we have discharge, which is at the end of our continuum. So that's the process. We're going to break down each one on its own and kind of talk through all of them. So the first step of the process is a referral. So obviously, anyone that's already getting therapy here at TherAplay has done this step already. So you've sought out a referral. And so you're usually going to always seek that from your physician. When you go to your physician, you're going to want to discuss developmental concerns with them. It's always helpful to have examples or videos if possible, so they can kind of see what's going on, be able to say, oh, they're having some gross motor issues. We need to refer them to some PT or speech or vice versa. So you must have a physician script with those diagnosis codes that are accurate for your child's condition in order to pursue those services. So sometimes we'll get kids come in and they won't have a script or they won't have a code on there, or the code will be incorrect. So we always want to make sure that we have the right codes so that way billing can go through and it all works out. We also want to ensure that hippotherapy is not contraindicated for your child. So that means contraindication means that it would be harmful for your child to participate, could be harmful. So we want to make sure that there's no things that might cause the child any harm. And some physicians are unaware of the contraindications of hippotherapy. So we have a list of those and we provide it to the doctor and they will sign off on what conditions your child may or may not have, just to ensure their safety. So that is the referral process. The next step is the screening and evaluation process. So the evaluation process looks a little bit different for each discipline. PTs look at those gross motor skills, coordination, those big body movements. OTs were kind of a we catch all. We'd work a lot on daily living tasks. We work on play. We work on sensory regulation. We work on fine motor skills, those kinds of things. Speech also will work on feeding, like swallowing, manipulating food in the mouth, working on communication, obviously with AAC devices or other methods. So each process is going to look a little bit different depending on what discipline you see. So when your child comes for an evaluation, we're going to be observing them during their play because a child's main occupation is play. So it may look like we're not paying attention to your child at all during the evaluation, but we really are. We're trying to talk to you. We're also watching to see how the kid interacts with their environment, whether it's with their siblings, whether it's with you as the parent, whether it's with toys that are in the environment. We're watching, we're assessing while we chat with you also. And going along with that, our parent interview is essential. So we really want to know, what are your goals? What are important to you? Because that is really what's the most important. Your child, what they want to do and what you want to do is most important. You sometimes see us using standardized assessments during our evaluations, and we use those to track progress. So you'll see us kind of pull those out occasionally, depending on what the child needs. And again, we're constantly observing and assessing. And after we complete that evaluation, we will synthesize all of that information that we got, and we'll develop a report and we'll send it off to insurance and the doctor for approval. And one note for this is that only one evaluation sent to insurance per year is covered. So let's say your child has a speech evaluation in February of this year, and let's say you decide, hey, this is not really working, we're going to stop speech therapy for a little bit, and you decide to discharge. Then you decide, hey, let's give it a try again in November. Well, only that one evaluation at the beginning of the year will be covered by insurance. Obviously, there's other things that go along with that, and you can reach out to management if you have any questions about any of that stuff. But only one sent to insurance is covered per year. So that is our screening and evaluation process. So the next step is intervention, which is the longest portion of the treatment process. So the intervention portion attempts to facilitate a child's engagement in the outlined areas of deficit that we identified in the evaluation, and we use play to facilitate that engagement. So we really, again, want to know what's important to you. You're the expert on your child. So if we come out and we're saying, hey, they were doing this, and you're like, oh yeah, they do that when they're hungry. You're the expert on your child. So any information about those kinds of little things about your child are so helpful for us to know, so that we can give your child the best care that we can. Progress reports, typically we complete those every 6 months, and those are when we look at the plan of care and all of the goals that we made, and we'll either make them harder depending on if the child has already is not doing well with those goals. We'll make them easier, and if they are doing well and they've met them, we'll say, hey, let's try a little bit harder of a skill. Or if they are kind of stagnant with their goal, we'll work on, hey, let's change this up. We'll work on something else for a little while. So that's really a good time to collaborate with your therapist, is around that progress report time. And then we'll also sometimes complete an assessment like we talked about in the eval. We will complete those assessments once a year if insurance requires them, just to track that progress and see how we're doing. At this stage, home exercise programs and therapist-parent collaboration are essential to progress. So completing those home exercise programs that your therapist give you, whether it's one activity a week, hey, put on one sock this week, like one day a week, put on one of your socks by yourself. That's still your home exercise program. So those things are important to work on at home too. And also, like I said earlier, that therapist and parent collaboration, those things are essential to making progress. So our last step is discharge, or what we like to call graduation. So we always want to preface this. Discharge is never meant to be a dirty word. It's a natural part of the therapy process. And another thing too, that we've talked about before in the back, discharge is really not an easy conversation for us to have or bring up, because we've developed relationships with you and with your family, and we want you to be successful, but we also have to be ethical in our process. So we'll kind of get along to the ethics part of it later, but it's never meant to be a dirty word. So let's talk a little bit about some of the reasons a therapist might suggest discharge or graduation, and those can include a parent might bring it up. They say, hey, I think my kid's doing awesome. I think we're ready to graduate. Or, hey, I don't think this place is working for us. We're going to go try somewhere different. So a parent brings it up. Another one is a plateau in skills. So a plateau is when progress on those goals that we've made has ceased over a reasonable amount of time. So we want to make sure that we give the child enough time to work toward a goal. We can't just give them a goal and 4 weeks later, we're like, oh, this isn't working. Let's get rid of this goal. We want to give them a reasonable amount of time to work on those skills. But we want to look for that plateau where we're trying different things and they're really not making progress in a lot of different areas. It may be time for graduation. Number 3, we have no new or different goals that are currently relevant. So family's not really identifying anything new or different. So that's another reason we would consider. Number 4, the child's skills are age appropriate for their diagnosis. So your child may not reach age appropriate skills, and that is okay because they're reaching age appropriate skills for their diagnosis and they're functional in their environments. So that's number 4. Number 5 is we as therapists have exhausted best clinical efforts with previously used strategies. So that kind of goes along with the other one. We've worked on a lot of different things. And so, it's time for graduation. So we've tried lots of different strategies and they're not working. We've collaborated with our team and they've given us strategies to use and they're not working. It may be time for graduation at that point. Number 6, another discipline might be needed. We have that happen quite frequently here where a kid will come into OT and they'll come and see me for a little bit. And then we determine, hey, they're older, they're 6 years old, and communication is really impacting our ability to participate in occupational therapy. So, hey, let's try speech therapy for a little while and really work on improving that communication. So that would be another reason, another discipline's needed. And then the last one is time commitments, financial situations, or increasing and decreasing services wouldn't be beneficial. So those are some different things that we might look at. And I do actually have a copy of this, which you won't be able to see right now, but we do have our discharge policy, and it does have pretty much all of these things on there. So if you ever want to kind of look at that and look through that, I'm sure someone will be able to find that for you and you can peruse that on your own. So yeah, that would be if discharge and graduation is happening for you. So let's jump into this section. I'm going to have you guys, if you have a pencil and paper nearby, I would like you to write down maybe 1 or 2 words that kind of go along with this statement. When the word discharge or graduation is brought up by your therapist, what are your first thoughts or feelings? So I'll give you guys a minute. You guys can kind of ponder it and write down 1 or 2 words that you might feel, some emotion words that you might feel when discharge or graduation is brought up. Okay, so we're going to get back to that in just a little bit. We'll kind of share our responses and see what kinds of words people came up with. But we're going to go ahead and jump into a fun slide about after graduation. So here's a list. It's not all inclusive, but here are a lot of different options that your child might have after graduation from any therapy clinic. So we have therapeutic riding, we have aquatic therapy. Your child might be able to participate in community sports. They can do social groups. There's counseling, lots of different options for our kids. So your therapist may have information on some of these, or they can gather information on them. Just let them know what you're interested in. I'm sure they will be more than happy to look into different options for you. I also wanted to bring up too, I have one of the flyers from our lobby about the education scholarship account. And it's a really cool program that the state of Indiana puts on. And it pretty much will pay for quite a few of these, if not all of them, different options for your child. So make sure you check into that. There's a couple of flyers here in the lobby that you can look into that a little bit. So another thing with after graduation, we also want to think about the needs versus the benefits of therapy. So you may be saying in your head, my child will always need therapy. That's just always going to be what we need. But we also need to think about, is it going to be beneficial? Are there going to be opportunities for your child to participate in one of these and fulfill a therapeutic need? So always kind of go back to that. Like, yes, my child may always need it, but are they benefiting from it right now? Would it be beneficial to participate in a social group instead of a one-on-one with a speech therapist? So consider that. And I really enjoy putting this list together and seeing all the different options out there. So with that, we're going to jump into the definition of skilled therapy. So I retrieved all of this from the Center for Medicaid Services. Medicaid obviously does a lot of our payment. We have a lot of children on the Medicaid waiver, so pays for a lot of services. So we always want to make sure that we look at their guidelines. So skilled therapy, according to CMS, is the therapy has to be provided by a qualified therapist or a qualified assistant, so a occupational therapy assistant, PTA, and those people have to be under the direct supervision of a therapist as appropriate. And the level of complexity and the sophistication of the therapy and the condition of the member must be such that the judgment and the skills of a qualified therapist have to be there. So the therapy must be medically necessary. So let's jump into what is skilled and what is not. So you guys can see this, but I'm going to go through a couple of these. I have some of our skilled therapy on the left side and not skilled over here on the right. So some examples of skilled therapy would be providing education to the family, would be recommending adaptive equipment as needed, giving varying levels of cueing, administering those assessments that we talked about. So those would be some examples of skilled therapy. And not skilled therapy would be just kind of observing a caregiver. You're not giving them any education. You're not giving them feedback, just kind of watching them, not really interacting. It would also be repeating the same activities or goals that we've targeted previously without progress. So I have had times where a parent will come to me and say, hey, we worked on toothbrushing a couple years ago and we weren't really making progress with it. Will you look at it again? And so in those moments, I will say, yes, I will look at that, 1 or 2 sessions. Obviously, I can't build my entire session around that, but I can definitely look into it. And if I see, hey, this child's kind of where they were, previously, then if I were to keep working on that skill again, it would be considered not skilled, unless I'm providing some kind of equipment or something like that to make it skilled. So there's just a couple of examples for you as to what is skilled and what is not skilled. So why do we have to be skilled? So the first reason is reimbursement. Everybody wants to get paid. So someone has got to receive payment, and companies that provide services and get denials of those services based on providing non-skilled care, they're not able to survive. So that's why reimbursement is very important. Ethics, which we also talked about earlier. So as therapists in school, we're really taught the principles of justice, truthfulness, integrity. We're taught all of these ethics. And so we need to be ethical in our treatment of each client throughout the whole process. And it also can discredit our speech, OT, and PT professions if we continue to submit claims that are denied due to the client not needing medically necessary therapies. So ethics is important. Maintenance therapy, which is defined as when the therapy procedures are required to maintain the patient's current function or to prevent or slow further deterioration, that the skills of a qualified therapist are required. So therapy services are considered skilled when the expertise of a therapist is used to develop or to design some kind of a maintenance program for that patient. But once the program's developed, can that be passed off to a parent? Can it be passed off to, their school? Can it be passed off to other people and done effectively? So that is when maintenance therapy is not considered skilled anymore. Evidence-based practice is another one, and we're going to look into that on this next slide. So evidence-based practice, as therapists, we have to consider the model of evidence-based practice in our treatment, which incorporates what you see here, patient preferences, clinical expertise, and best evidence. So this includes seeking out research studies and protocols that show real progress. So why do we have to do this? Well, we see more effective treatment techniques. It ensures that our treatments actually work with our clients. So why would we try things that don't work? That doesn't make sense. So we really want to find things that are effective for the client. It also improves outcomes with family intervention. So it allows us to show the effectiveness to our families when they asked, why do I have to do this? Why do I have to do this home exercise program? Well, here's why. We can show you the research as to why this is important. It also is important because it helps us defend our services to payers. So it shows the insurance companies that we're using treatment that's backed up by research. It also ensures that our clinical skills are up to date and make sure that, say I've been out of school for almost 10 years now. Things have changed a lot since when I started out in OT. So I really want to make sure that I'm keeping my skills current and, going with the flow in terms of what is research backed. So all this to say, yes, we do take patient preferences into account, but we also do need to look at the evidence of treatment styles, as well as using our expertise to make a judgment call as to whether therapy is still considered skilled. So in looking at evidence-based practice, episodic care has emerged as the primary model for therapy services. And episodic care is defined as the delivery of a specific healthcare service for a specific period of time. So they're really showing that this is effective because these companies that you see listed here and other companies that have been using this see a lot of great gains in motor performance in their children, faster achievement of their goals. There's a lot better adherence to recommendations provided by therapists. It really emphasizes activities and participation. So I think it would be really cool if a family comes in and says, hey, we want to really, really work on bike riding for 12 weeks. So it really is motivating for the parents and for the child to say, hey, we're going to work on riding a bike. And by the end of these 12 weeks, we're going to be even closer. So it has a lot of buy-in. So all of these companies that you see here, there's some big ones on here. We've got Cincinnati Children's, we've got Vanderbilt, Nationwide, Dayton. So all of these companies, as well as the area company 321 Go Kids in Newcastle, they've been implementing episodic care and been seeing a lot of great results out of it. So these companies that are listed here, they're really focusing on short-term plans of care. So usually like 12 to 26 weeks before they graduate their clients. And the clients can usually come back after they've done a home exercise program, they've done some kind of community activity, they've done a social group, or they just needed a therapeutic break for a little while and they're ready to learn more skills. So these companies are seeing a lot of good change in their clients. So let's go back to this, and I want a little bit of some audience participation, if you can. So let's go back to our question that we asked earlier. When the word discharge or graduation is brought up by your therapist, what are your first thoughts or feelings?
We'd be very proud of the progress, but also sad because we enjoy, it's the best part of our weekend, and we just enjoy being there. So
Yeah. So proud, but sad. Yes. What about you, Kara?
I'm not a mom, but from what I've heard from my years of experience in outpatient, abandonment has been the #1 term I hear from parents. And so
okay, abandonment.
That comes up a lot. Yeah. But then I have tried these episodes of care before, and one of the words, parents are actually found relief. They didn't know they could ever take a break. They had no idea. They thought this was part of life forever. And I think it did bring them some relief ultimately, that they could take a break, come back when they're ready, and start up fresh.
Cool. Kathy, do you have any words?
I think fear. Sometimes our parents worry that that they won't get the spot they like back, or the timing that they like. So I think I hear fear associated with it a lot.
Yeah. So you guys hit on a couple of the ones that I have. So I'm going to throw a couple of these up there. So we had fear, like Kathy said. We had relief, like Kara said, abandonment. I also had lack of confidence in both themselves and in their child. We had anger, happiness, which I need to change the color of that, confusion, and grief and sadness. So there was a study that was done by Nova Southeastern University doctoral student. It was called Enhancing Collaboration Regarding Long-Term Therapy Planning for Children with Chronic Conditions. So it was based on a strategic plan from Cincinnati Children's Hospital that they wanted to improve their quality of care while also reducing their cost. So there's also a lot of evidence out there about continuous care, which is therapy over multiple years, being more expensive in the long run in comparison to episodic care. So there's a cost thing in there too. So for this study, therapists completed a self-management training. So they worked on using motivational interviewing to increase the client and family management of the condition. And they also gave the therapists a lot of tools to use with the clients to support developing those skills. And then parents were also interviewed at the beginning of the process and at the end of the process. So this study, I said this yesterday, but this study really hit me. I'm not a parent yet, but reading some of the quotes was very eye-opening for me. And I've heard them from parents before, but just seeing them on paper and being able to connect it to our parents too, it meant that it's a big overarching theme, and it's not just here at TherAplay, it's everywhere in the therapy world. So we want you to know that we hear you. It's a hard thing, and it's a hard process. So we're going to kind of jump through a little of these. So the circles you see are different categories that the parent interview, they were all coded into specific categories. So we're going to kind of go through each one, and I have a couple of quotes for some of them, and it'll just kind of talk through about what the parents brought up as part of each one. So stress. So one of the quotes for this one was, "Sometimes we feel like we can never do enough as parents of a child with special needs." Another one was, "Hearing that we needed to take a break was hard. It's scary for me to take a break." So these parents really feel like they're the care coordinator for their child. So they feel like they have to do a lot. They have to talk to doctors, they have to talk to the therapist, they have to collaborate with the school team. It's a lot. And so they also feel like they need to follow through with their home exercise program. And it's part of their routine. So it's something they do every week. So they also worry too about regression in the child's skills. So that was the stress portion of it. Uncertainty about the future was another. So a couple of quotes from that one was, "I think that in general, he's always going to need some sort of therapy. And I just want to continue on, especially if he's making progress." So a lot of this one had to do with a lack of a long-term therapy plan. The parent really didn't know where they saw their child, 10, 20 years from now. And that was very, scary for them. And another part that went under this was they're unsure of their child's potential. They have a lot of worry. They have trouble setting realistic expectations for their child. They feel like they'll be done once their skills are age appropriate. And they're worried about their child not achieving that maximal potential. So that was the uncertainty about the future. And then relationship with therapist was the next one. So parents really appreciated when their therapist asked for input on their child's plan of care. They're thinking, "Oh, my child has such a good relationship with this therapist. I don't want to end that. They're doing really well with them." So it's really hard for the parent to want to stop. And so, sorry, I'm turning my page. So they also, under this one, they feel abandonment is under this section of relationship with the therapist. And then the last one was value of sessions. So their appointments really give them accountability. Hey, we need to be here every week at 2:00. And they're getting accountability for doing those things that are recommended to them. The therapists have knowledge and expertise. we've went to school, we've been trained to do this, so they have the knowledge and expertise. The parent learns during the session. Therapy helps their child. The parent worries about missing something, like, some kind of, developmental milestone that the child's not meeting. And a child's needs continually change. So those were all of the things that went under the value of sessions. So at the beginning, of this study, parents had very, very emotional responses. Most parents pretty angry or concerned about the topic of discharge or graduation. But after implementing all of these motivational interviewing, all of these resources, when they were provided to the therapist, who then provided them to the family, the parents, once they were interviewed at the end of the study, they reported no frustration, no anger. Honestly, they had positive or neutral responses to the idea of taking a break. But there was the thought of, hey, let's get a little bit of control over when this break happens. So parents really wanted to kind of have some of those things in their control, as to when to have the break, how to decrease the services, how to reschedule with the same therapist once they come back. So those were all very important things to the family. So it was a very eye-opening study for me as a therapist. So yeah, check it out if you get the chance. So let's jump to this. How can we help as therapists? So the first thing we can do is empower you, support you, which that we're here for you. We're here to listen. Like I said earlier, we are still learning to have those difficult conversations. They're not easy to have. But we always go back to, hey, is it ethical that I'm seeing your child? And is it skilled therapy? So hear us out, even though it's hard. Also, we can give assistance with a long-term plan for your child. We can give you some feedback as to what we've seen in terms of your child, their diagnosis, what we might see for them. Also, another thing is we can modify home exercise programs for you. We can make them really simple for you, kind of like I said earlier. Hey, put on one sock, 4 days this week, like have the child work on that. And that's the only thing you have to work on this week. So we can really pare that down, and we can also make them so functional that they're already part of your routine. So ask us those things. We can definitely do that for you. We can be honest and realistic in what potential we see. That kind of goes along with the long-term plan. And then also, we're here to help you problem solve. We're here to help you in whatever way we can. That's our job, like I said. So yeah, that is our presentation. So